Well, good morning, everybody online. I got 9 o'clock. We're gonna get started. A couple things that we'll talk about after we're done. I saw a couple of people putting their PSID in the chat. That's perfectly fine. I will tell you this, at the end on the QR code, that is one of the things you need to put in there is your PSID number, so it'll work out okay. We're gonna start our first presentation today with Will Losi. He's gonna be doing some STEMI and stroke stuff for Union Clinton and Terre Haute. Let me know if you need anything and everything you guys do.
I don't think so.
All right, does this thing gonna work?
Sure.
Good morning, everybody. So I've got Stimmy and a stroke from Clinton and a Stimmy from Terre Haute. So our first case today, we've got an 85-year-old male, history of BPH, hypertension, seizures, and high cholesterol. Family called 911 for a male patient who had fallen outdoors. You're definitely go here. EMS was notified at 13:57, arrived on scene at 14:05, departed at 14:22, so 17-minute on scene time. Stroke alert called at 14:35, and arrived there in Clinton at 14:41. Dispatch called for a male patient falling outside. Upon arrival at the scene, the patient was sitting leaning up against a firefighter. Patient's wife says that she went outside, found him on the ground, was unsure how long he had been out there. Patient's alert and oriented, POC 15. Unknown if he hit his head, but fire advised, and the patient was laying with his head against the house when they arrived. C-spine back was felt, assessed for abrasions, contusions, bleeding, step-off, deformities, and pain, none were noted. Patient's wife advised the team that their patient was not on blood thinners. However, since they were unsure whether he hit his head, they did maintain manual C-spine. They attempted a C-collar, but he was a little too cachectic to make that work. So they maintained manual C-spine while they got him up onto the cot. They did notice that he was extremely weak and they had to place him on the cot. And they put him in a C-collar and secured him with rolls of tape. Patient's wife mentioned that he had never had the weakness before, so they did a stroke scale. Was unable to lift his left leg or squeeze with his left hand. Had some left facial droop around the eye. Negative for slurring of speech. Patient's reports that it was a diabetic. Pupils are pearl. Blood glucose of 368. GCS remained at 50. Transport was started emergently at Union Hospital Clinton for being a stroke alert. Stroke symptoms were managed or monitored throughout. They did notice some changes. Was unable to track with his eyes, neglecting the left side of his body. Had a forced gaze to the right side. I was unable to look at the left who reflected. Patient was able to identify objects, but told the team that he couldn't see the fingers. Had abnormal or no sensation in the left leg, could feel it touch his right arm, could tell exactly where he was being touched. They continued to assess throughout transport. Blood pressure elevated while en route, went from 160/99 to 190/107 during transport. Was Cincinnati stroke scale advanced positive. Upon arrival to the hospital, he was able to move his left side a little bit, but wasn't following any commands at that point. They did call in with an eye hernia and a stroke alert 5 minutes before arrival and was taken directly to CT. At 14:44, we arrived at Clinton. Stroke was called and the patient was taken direct to CT. 14:58, neuro page was sent out. Neuro consult began at 15:02. 15:34, TNK was administered. The door needle of 50 minutes. This was delayed because they had to manage his high blood pressure prior to TNKing him. 15:18 was taken back to radiology for a CT of the head to rule out LVO. Had some stenosis bilaterally in his carotid, but was negative for LVO. At 19:54, the nurses noticed that he'd been getting progressively agitated. They took him back over to CT. At that time, found a new subarachnoid bleed along the posterior and lateral aspect of the right temporal lobes. 21:18, left by Transcare for Union Hospital Terre Haute. Oh, see there.
There you go.
Arrow. Good times. Yeah. So here you can see looks kind of like a cotton ball. So that was his subarachnoid that he had developed post TNK. Here in Terre Haute, shortly after arrival, developed some seizure activities. He did have to get intubated to protect his airway. Started him on Keppra, which controlled the seizure activity. Was able to be extubated. Was able to discharge to med rehab on the 14th. However, they didn't have a bed available, so PT kept working with him while he was on the floor. And on the 18th, he was actually able to go home with home physical therapy. So this one, they utilized Cincinnati short scale, Vanwell, early pre-notification. It's able to get cleared. Was a delay in the TNK. They had to get a nicardipine drip going to bring his blood pressure down to tolerable range before TNK. They noticed the elevation and agitation and identified the non-surgical subarachnoid. Our second case is a 55-year-old female. History of asthma, anxiety, hypertension, carpal tunnel. Presentation was 911, called for a fetal patient with chest pain and shortness of breath. EMS notified at 03:56, arrived on scene 4:03, departed 4:14. Stimulant was called at 4:26 and arrived to Terre Haute 04:33. Dispatch for a female with chest pain and shortness of breath, conscious, alert, and oriented ×3, airway open, self-maintained, breathing at 14 minutes. Complaining of chest pain, was scheduled for a cath to be done that morning in Providence. Thought to have a blockage. They were onto something there. She was awakened with chest pain that morning, mid-sternal, non-radiating, rated out of 9 out of 10. She had taken 3 sublingual nitro with low relief at home. Denies nausea, vomiting, denies shortness of breath at that time. Cardiac monitor with sinus, 12 leads showed elevations in 1 AVL V2, depressions in 3 AVR V3. Transmitted via E-bridge, restricted 110. All right, aspirin 324 was given, saline lock established, and 1 sublingual nitro monitored. And did decrease while en route to Terre Haute. They were contacted Iron for further orders. 4:43, patient arrived in the ED. 4:45, EKG showing inferior STEMI. 5:15, the patient arrived in cath lab, and 53 after vessel was bleeding open. First medical contact of 110. Reported blue for the facility of 70 minutes. There you can just see the beginnings of the nub. They were able to reestablish 100% LAD blockage there. So this one had early notification, stimulant by E-break and iHern. When I was reviewing Union side documentation, the ER pre-arrival sheet did not have that it was a stimulant brought down. There was no mention of the E-bridge and the ED record on this patient either. So notification or activation didn't happen until after they arrived. So some form of communication dropped there. For our Terre Haute STEMI, 57-year-old male, history of CHF, CAD, hypertension, and smoker. One call for a patient with chest pain. EMS notified at 4:29, arrived on scene at 4:40, departed at 4:51, did a stimulant at that time, and arrived here at 5:01. 57-year-old male, hospital history of hypertension, cardiac stents 10 to 12 years ago, complaining of acute onset of chest pain, which woke him from his sleep 15 minutes before calling 911. Taste of pain is a pressure-like sensation along the midline of the upper chest with radiation into the left upper extremity, endorses some associated mild shortness of breath, denies any other signs and symptoms. Patient is ashen and clammy. Took 324 of aspirin just prior to EMS arrival. EKG shows STEMI. Nitro was given with medical relief. Had some soft pressure after that, so they give the bolus. Monitored while arrived. Prior to him arriving, they did activate the cath lab and cardiology on this one at 4:06. Arrived at 5:03, 5:06, EKG again showing STEMI. 5:35 arrives in cath lab. 6:01 vessel balloon. First medical contact. Order balloon 58. Fantastic. Again, 100% LAD. See a little uptick. List of blockages. Reestablished flow. On this one, all time goals were met. Early notification, reactivation. It's a beautiful thing that happens.
Well, appreciate it. Next up is gonna be Beth Harrison. She's gonna do the stroke for Union Hospital Fair Road. Leave starting next month. You'll be doing patient strokes. Awesome. Great. I would use arrows because we'll broke with me. Oh, you can't have nice things, that's right.
Good morning, everybody.
You're-
History of this case, he was a 72-year-old male. He was independent, lived with his wife. Medical history included hypertension, cardiomegaly, hyperlipidemia, hyperthyroidism, myocardial infarction, GI stents. So all the good stroke. Yes. On this, EMS was dispatched to a private residence. Upon arrival, they found the patient sitting in a chair in his basement. His last known well was at 15:45 for his wife. His wife stated he hadn't been feeling well that day for the last couple of days, but he had been acting normal. He went outside and checked the weather because it was one of those nasty snowy days we had earlier this year. And when he came back in, she just heard him yelling from the basement. So she went down, called EMS. He was alert and oriented, but he did have right facial droop with left-sided weakness. His finger stick blood sugar was normal. GCS was 15. 12 leading EKG showed sinus rhythm. His BP was 242/141. And they did start a 20 gauge IV. Patient had to be carried from his basement by EMS, but he was able to stand with assistance and pivot to the cot when they got him to the door. The Cincinnati pre-hospital stroke scale was completed. There was no VAN score. Stroke alert was called to Union ER at 16:49 with an ETA of 10 minutes. EMS noted that the patient was on lumbrokinase as a home medication. In response to the whole transportation issue was delayed due to the weather. EMS response time last known well at 15:45. EMS was notified at 15:52, dispatch at 15:53, en route at 15:55, on scene at 16:27, and outpatient at 16:29. The depart time from the scene was 16:32. Stroke alert was called, and they arrived at the Union ER at 16:58. In the ER, our processes were followed. Patient went directly to CT room 3 for EMS cart. EMS gave a good report to the nursing staff. The patient's NIH-SS was assessed at 13, so it was a pretty significant stroke. And you think you're having a really good stroke when you get about a 10 on that number. So he was up there. CT, the stroke was completed at 7:47. Was negative for a bleed. His BP was 230/137, heart rate of 97, and a SAT of 92 on room air. We did have to give labetalol until a neuro was consulted. The decision was made not to give TNK to the patient due to him taking a lumbrokinase. And a lumbrokinase is a fibrolytic enzyme that is derived from earthworms that is known to dissolve blood clots, and it is not a prescription medication, but a supplement. So I think it's a really good catch that we caught that he was on a medication like this because it wasn't a prescription. And his GI had recently was significant, which required surgical intervention at an Indianapolis hospital. So they did decide not to give him the TNK. The CTA was completed at 18:45. Did not show an LVO, but it did show an area of reduced blood flow. Neurointerventionalist was consulted. They decided to go ahead and transfer him to St. Vincent for advanced treatment. Even though he didn't have the LVO, they thought they may be able to intervene on that restricted area. At 21:41, the patient was transferred to St. Vincent's by ground transportation. They were not able to fly due to the weather. When they got in there, they did repeat some testing on him. They were unable to do any interventions because the lesion was too high and it was just too high and too tight to reach. The patient did have a length of stay of 5 at the Indianapolis hospital. He was discharged with an NIH of 7. His speech, he had dysarthria and expressive aphasia, left upper extremity weakness of a 3 to 5 strength, and left lower strength of 5 to 5. So he was able to transport, but a lot of upper body issues. and he was scheduled at home on outpatient therapy. The strength of this one, the Cincinnati pre-hospital stroke scale was completed. No van scale. The stroke alert was called, and it was noted on the stroke alert that he was on the lumbar kinase, which I think was a really good catch. All of our protocols were followed. He went to CT per cart, and this case had particularly good documentation by EMS. The narrative was very descriptive and very, it was a very good documentation case. So I don't know who wrote that, but a very good job. That's all. Any questions for me?
Thanks, Ben. Appreciate it. Tina, you're up. Tina's gonna do our trauma report. I think she's been waiting for this one for a while, so. Remember when I saw which one you picked.
Yeah.
Yes.
So, I think a lot of you know, that we get wrecked from, February, it was at 46 and 42. Highway 46 and 42. That was about the best picture I could find of it. There were, 3 cars involved, 2 people in the van, 1 person or 2 people in the truck?
One in the truck, two in the
Two in
van,
the
and then
van,
there was
and-
another car on the
Yeah,
other side.
the other one on the other side. So 3 of them came to us. There was a husband and wife together, the wife expired. This is the older gentleman, he's 75-year-old male, it's an MVA. 911 call came in at 12:51, dispatched at 12:58, en route 12:58, on scene at 13:06. Departed at 13:31. And he moved on at 13:41. So called dispatch was 7 minutes, dispatched en route was 0, en route to arrival was 8 minutes. On scene departure 25 minutes, departure to arrival in ER is 10 minutes, so the total 911 to arrival was 50 minutes. They all had to be cut out of cars. The EMS report, dispatch for MVA entrapment, seen a multiple vehicle accident with multiple entrapments. The crew on arrival assisted with traumatic arrest, which was the wife, the older gentleman, while another crew extracted a 75-year-old male. Crew held C-spine during extraction, and then the C-collar was placed. The passenger was in the passenger seat of the vehicle wearing a seatbelt. There was major damage to the front passenger side of the vehicle. From what I could see, it was the whole front. The patient was alert and oriented, stated that he was on blood thinners. He had a patent airway at that time, was breathing normally, he had prolonged extrication. Blood pressure was 84/5, pulse 99, rest was 90, or SAT was 95 on Romer, and GCS was 15. They started an IV form saline, gave the fentanyl, secured him with head blocks, vitals were taken, of course, multiple deformities of the lower extremities. He had right upper and lower leg and ankle deformity, left lower leg and ankle deformity. Lower extremities were stabilized using blankets. They couldn't obtain pulses in the lower extremities. The EMS note continued, chest was noted to have deformities on left side. Left sound was diminished. They started a 16 gauge and gave him a second dose of fentanyl. So he had 2 IVs. I heard called with a trauma alert. Pre-arrival notes that there was a femur deformity on the left, and there was a multi-vehicle alert or trauma alert. Blood pressure is 130/90 at that time, 114/95 SAT. Trauma activation was a level 1, call it 1338, and the trauma surgeon was already there. So he was a level 1 because of his blood pressure, and it was a multi-trauma. Just from what we heard, we knew it wasn't going to be a good one. So the patient arrived 13:45, vitals were 97.7, pulse was 127, rest was 43, blood pressure 146/129, SAT was 94. He was on a non-rebreather by then. He was awake and alert. I was in this room. He was pretty anxious and restless. GCS was 15, C color and backboard. He was nauseated on arrival, thought he was going to throw up, so he was intubated to protect his airway. I became hypotensive after intubation, 57/41. They started MTP. 94/77. And then up to 134/96. They did a fast, it was negative with suboptimal views, Doppler, pupils bilaterally. As the compartments were soft, decreased fluorescence on the left, chest x-ray, thorax. They put in a chest tube, by trauma. On return from CAT scan, he became extremely hypotensive. There was concern for cardiogenic or neurogenic shock because we couldn't find an active bleed at that time. So at that time, he had 4 peripheral IVs, an art line and a central line. Anchored fully, split his right lower extremity. He was maxed on the norepi and lev-fed. We started vasopressin. He had the MTP. We started second MTP, gave him fentanyl and had a tetanus. His echo, because we was worried about cardiogenic shock, showed ejection fraction 70 to 75%. Ortho came down and saw him, said put on a pelvic binder. They put traction on his right femur, left knee immobilizer. And at that time, they said they were going to wait. They wanted to do more films in the morning, not taking the surgery then because he was unstable. His imaging showed comminuted fracture of the spinous process C5, fracture of the right transverse process C7, fracture of the right transverse process T1, T2, and possibly T3, fracture of the posterior right first, second, and possibly third ribs, fracture of the posterior left second and third ribs, on left pneumothorax. It is CT of the left spine. Acute fractures of the right L1, 2, 3, and 4 transverse processes. There was a fracture of the sacrum left laterally. CT of the chest, fractures of the 4th through 8th ribs and right first and second ribs. There was a left pneumothorax. Left side chest tube was present. CTA with aorta, there wasn't really anything significant in that. Pelvic x-ray appeared to be acute fractures of the lower pelvis on the left greater than the right. They recommended a CT of the pelvis. Chest x-ray. No signal. Left hydropneumothorax, diffuse interstitial and airspace opacity, and left river fractures. Labs hemoglobin was 9.3, iron 1.43, glucose 154, AST was 69, CK was 1438, and stroke was 48. ABGs page 7.279, PCO 247.2, PO2 395, 5 22.1, impact -5. The drug and alcohol was negative except for benzos. His diagnosis was MVA, hemorrhagic shock, left pneumothorax, cervical spine fracture, lumbar vertebral fractures, rib fractures, traumatic rhabdo, metabolic acidosis, pelvic hematoma in the male, right femoral shaft fracture, left tibial fracture. He was admitted by trauma to ICU with ortho and hospitalist consult. Was on the fentanyl, probe, lactated ringers, norepi, his condition was unchanged pretty much throughout the night. He was kind of just neurogenic surgery. Goodman Campbell consult said he wouldn't require surgery for his spine, the protrusive fractures, but they recommended transfer to St. Vincent or transfer to a trauma surgery due to polytrauma. He was transferred later to St. Vincent. We didn't transfer him from the ER at the time. They were not able to fly. He was pretty unstable and felt like he was too unstable at the time to transfer by land. But and then when he was transferred upstairs, as soon as the hospitalist was able to become transferred, they made it when we got here. So, do you guys see any opportunity?
Well, she's being way too nice. We messed up. We
I'm
should have
not
gone.
done.
She is being way too nice. And I'm actually gonna let her give her second case because it's the same wreck. And then I wanna talk about it because we should have shipped both these boys out.
Yeah, we can just cover them both. Well, I'm not done. I am not done. Case study, the second one is a 20-year-old male.
So this was the pickup.
Yeah, this was the pickup. A 20-year-old male is an MBA, 911 call at 12:54, dispatched at 12:54 en route 12:59. On scene at 13:18, departed at 13:34, and at Union at 13:46. Times called dispatch was 0, dispatched en route was 5 minutes, en route arrival was 19 minutes. On scene to departure, 16 minutes. Departure to arrival in ER is 12 minutes, total time, 52 minutes. So this was the 20-year-old male that was dispatched for MBA. On arrival, they were directed to the patient by the fire department. Patient was the driver of a truck that had several feet of intrusion in the front. Patient was entrapped, laying left leg pain. Took several minutes to get him out by fire. He was removed towards the first place to a C color and then on the backboard. They immediately saw the deformities of both legs. They were pretty severe. IV ×2, they gave him saline, fentanyl. He was, had pain in both legs, in both femurs, indicating probable fractures. They were open bilateral tip fib fracture, left knee fracture, and deformity to the right ankle. They gave him another fentanyl, 100 of fentanyl, and gave him antibiotics and seeing good for them. Blood pressure 139/87. Heart rate's 100, rest 22, SAT was 97 on room air. ECS was 15, pain was 10 out of 10. Denied any shortness of breath, chest pain, neck or back pain. Abdomen was soft, pulses and positive pulses in both feet. They called an IHERN with trauma alert. This was also a level 1 activation at 13:45. Trauma surgeon was there already. It was a multi-system trauma. Arrived in ER at 13:52. Vital is 97 on arrival, 97.9. Heart rate is 101, rest 24. Blood pressure 144/83. That 100% on room air, and DCS was 15. He was a restrained driver in multi-car MVA. He was entrapped, dragged with C color on. He had pain in his arms and throughout both legs. He had obvious deformities, they were very obvious, and open fractures. Stable pelvis, open tip fib fracture, and knee on the left, externally rotated and shortened the left lower extremity. Obvious fracture of the right ankle. 2+ radial pulses and 1 plus, and 2+ on the right. Fast was negative. White count was 11.6. Hemoglobin 12.7, potassium's 3.3, and glucose 248. He was positive for pot. Again, I said level 1 trauma. Imaging, CT of the head, there's no injuries, CT of spine, no acute injury, facial, no acute injury. Chest, abdomen, pelvis, there were acute displaced fractures of the anterior aspect of the right, 3rd, 4th, and 5th ribs, some surrounding soft tissue, swelling. CT of the bilateral lower extremities, an acute transverse to oblique fracture of the mid shaft of the right femur. There's a small comminuted fragment, and the lateral and posterior displacement of the distal component. Mildly comminuted oblique fracture of the mid shaft of the right tibia. Is a very comminuted fracture of the distal shaft of the right fibula. Few fractures in the mid to distal shaft of the left femur. Intervening component up to 10 centimeters in length. The middle component is displaced posteriorly and angulated anteriorly. There is an acute fracture left. Proximal tibia involving the tibial spine, moderate hemarthrosis, and the left knee joint likely due to, and I can't see the tibia fracture. Diagnosis: fractures of the right ribs, right femur fracture, left femur fracture, hemarthrosis of the left knee, traumatic fracture flat. Halfway left tibial fracture, right tib fib fracture. So the trauma surgeon admitted him also. We couldn't get air transport at that time. Ortho consult, Simon ER, he went to OR from ER. Pre-op diagnosis, left segmental femoral shaft fracture. Left patella fracture, grade 2, open left leg centimeter laceration with traumatic fasciotomy. Right femoral shaft fracture, right combinated tib fib fracture, open grade 1, right unstable bimalar fracture of the ankle. They did an IND of the left leg laceration, IND of the left knee, nail fixation, the combinated right tib fib fracture, open reduction, internal fixation, the right ankle fracture, retrograde and medially, fracture, the fixation, left femur fracture, retrograde, nail fixation, the right femur fracture. So the post-op, dressing in place for 7 days, said there was gonna be a lot of drainage from that. NSAF times 48 hours, aspirin, BID, is what that's supposed to be, times 4 weeks. NCDs lies in half, follow-up 4 weeks. Non-weight bearing right and lower extremity, weight bearing, on the left lower extremity, PTOT, and then to ICU post. So the next day I went up and saw him about 7:30 in the morning. His heart rate was 140 to 170, temp was 102, and I didn't put in here his lactate was 4243. I had increased anxiety and pain. They had a hospitalist cardio and intensivist consults. They said that the heart rate was elevated due to pain. Was saying maybe the heart rate and the temp was up because it was reactive. He had an O2 on at 2 liters, had an echo done. Didn't really show much of anything. And then later in the day, he was transferred to a medical floor. I just want to go back and say, that's the beginning of the problem right there. Day 3, his hemoglobin was 6.5. They gave him a unit of pack cells, hemoglobin, repeat hemoglobin was 6.3. He was unable to work with therapy because of shortness of breath. He was on 7 liters in cannula. Chest x-ray was negative for PE, but he did have some infiltrates. And then at that point, he was transferred to a cardiac monitor unit. And you can see the trend going here now. Day 4, they had to give him another unit of blood because hemoglobin, say, was still 6 something. His hemoglobin at that time was backed up to 8.1. He got worse in the morning. They called another rapid. He was confused. He was pale. He pulled off his oxygen. His SAT was 23% documented. They placed him on a non-rebreather, then BiPAP. His SAT's up to 85. He was alert but anxious, so they gave him some Ativan, remained on the cardiac unit. Chest x-ray showed developing ARDS. CTA test to rule out PE. There's infiltrates, but no PE. Then they transferred him to ICU because he continued to get worse. He was intubated, placed on the vent, and road prone. They consulted with St. Vincent, who accepted, said possible ECMO. And the family, or they couldn't transfer him at that time either because of weather, and he's pretty unstable. Chest x-rays showed a new pneumothorax on the right, some mediastinal shift to the left, and a probable tension pneumothorax. So he had right and left open tube thoracostomy, and central line was placed by trauma. His sedated, paralyzed pressors, Lasix, Lovenox, antibiotics. Cardiology consult as rule out CHF, BMP was 308. Elevated liver function test. Still hasn't transferred. Day 5, bent 100%, FiO2, peak was 16, he's still on the road prone. Chest x-ray, persistent multifocal bilateral airspace disease. ID consult, he said continue the current antibiotics, and they put in a feeding tube, did lower extremity Dopplers, which was negative. Now, this time, they finally did get, decided to transfer to St. Vincent. They got a patient accepted. They had the air transport all set up and the family chose to give the bed up. They felt like, I talked to his dad, the dad felt like he was getting care here just fine, even though multiple people had told him that there would be teams of people take care of him up there. And they said it would be kind of a hardship for them to go back and forth. So his hemoglobin 6.6, they gave him more blood. He was still on vent, FiO2 was down to 90, still on rotaprone, bilateral chest tubes. They were weaning the pressors, temp was 997, blood pressure is 162/102. Pulse 66, rest 30, SAS 99%. White count is 17.5, mag 2.9. He had a rectal tube. He had a girlfriend who had been staying with him, who they had to send home because she wasn't feeling well. Come to find out she had the flu. Then the patient got the flu on top of everything else. So they gave him Tamiflu, IV Venic. Trauma again recommends transfer, but the family was kind of holding that back, but they didn't want him moved. Day 7, he was still tacking, hypertensive. Lab was unable to do a urine fat. I think they were trying, from what I understood, they were trying to rule out some kidney failure. Excuse me. Chest X-ray, diffuse interstitial and aerospace opacities that were unchanged. Remained on the vent with high FiO2, 75%, 15 or 14 a peep. Trauma study should be considered for echo, recommended transfer. Ortho suspected fat emboli syndrome, DC Lovenox. Vitals were pretty much hanging. It's still in ICU, it's still on the vent, FiO2 70%. Sedated, paralytic, suppressors were off, he was still on rotaprone. Hemoglobin went back down 6.7, they gave him more blood. Chest X-ray, really didn't show a whole lot of change. Interstitial pneumonia, day 9, SAT was 85 to 98%. Blood pressure a little bit better. Still in ICU, still on the vent, 70% FiO2, heat 15, sedated, paralytics. Chest X-ray showed a little bit of improvement in the pulmonary edema and the pneumonia. Trauma spoke with the family again. They finally agreed to transfer, and he was transferred to St. Vincent Air. Kind of hard for me to get good pictures from the CAT scan, but these are some of his fractures. They were nasty, nasty. I mean, his legs were going, each part of it was going a different way. So that's the older gentleman ended up going to first case. He went to Kindred for rehab. There was concern up there because he was hemorrhaging in his pelvis, that had enough blood that had displaced his bladder. He did have surgery on his legs and on his pelvis. And this gentleman, he went to an acute rehab, and I think he was discharged the end of, not last week, week before, right? EMS did a fabulous job. Good job for you
So my
guys.
first question is, anybody in here that was on this record, because there was a multi-agency response, really, a room full, none of you?
Wow. Yeah.
Wrong shit.
Okay, so first, okay, you're the only one there, so I gotta put you on the spot. How do you feel like it went on scene?
I actually would prefer to do like a case study on it, so I mean.
I'd ask you.
Because from my perspective, it was like a waltz that went perfectly. I mean, Barry got a call, I got a call, and the secretary got a call. That is one of the best things you can do for us, because immediately, we both knew, okay, we gotta go out. They stopped what they were doing, we went out, we cleared rooms, we were ready. It was phenomenal. I know Dr. Lopper was there, but I can't remember who the other guy was there. So there were 4, the husband and wife were in the van. I know it's gonna mess you up, but can you
Yeah,
go back
that's
to
okay.
the pic? I want the picture of the wreck. So, one of the firemen said, I said, what happened? And he goes, none of us know. He said, literally, it looks like people just dropped crash cars out of there. So the husband and wife were in here, okay? The young man is in here, and then we didn't get this one, regional got this one. So calling us was phenomenal because if you guys try to help us, don't worry about it. Just call us and say, hey, we got 15 patients. Hey, we got 4 patients. Don't worry about it. Don't try to be nice. Well, that's for us to figure out. But all of you are so good to us because you know we are always up against the wall that you're like, "Ah, I got 4. Don't worry about it. Okay. That's for us to figure out. We will do it every time. Because I will tell you, the minute we got that call, people were going in beds, people were going in chairs, people were going to the waiting room, and we cleared all those rooms. We actually got her. Okay. She was a traumatic arrest. Technically, she probably died on scene, but she came in. I think they worked her for less than 5.
Yeah,
Right?
it was like
It was
3
just
minutes.
minutes, enough for us to go, oh, okay. I will be honest and completely transparent. We had a very inexperienced young trauma surgeon on who started making bad decisions from day one. And I will tell you, our nurses know what they're doing. Our medics know what they're doing. And it behooves the docs to listen to us, okay? So we knew we were could possibly be getting 4. We got her, and then there was a delay because there was an extrication. And I will tell you, the only thing from the EMS point that I felt like maybe should have been a little bit better was once they got here, we had a lot of baby medics who were in every one of those rooms. And I finally said, what patient did you bring us? Oh, I brought this one. Okay. I think we've lost our 60 seconds of silence. So we are gonna go, that's one of the things on our to-do list, okay? Because that is very important for you and that's very important for us. Because at that point, we were like, he was the driver, he was the passenger. Oh, he wasn't in the van, he was in the van. The kid was in the truck, the kid was in the car. And I'm like, okay, time out. We gotta figure out what's going on here. So we finally get everybody matched up with their patient. And we learned that she was the driver of the van. Husband was the passenger. But we were also told they had to, so I'm assuming because of this, I don't know. It's been a long time since I've been on the streets. They had to move her to get to him. He's the only one that had a greater than 20-minute scene time. She was in and out quickly. The kid was in and out quickly. So the passenger of the van was the only one that had a delay, and even that it was within a half an hour.
Oh, yeah. It was like 20 minutes.
Yeah, the times were fantastic considering what you were dealing with. So then when it arrives here, right, so we have her, we've already called time of death on her, charge nurse makes a phenomenal decision and they move her over to peds trauma. So she's kind of tucked out of the way. He unfortunately didn't know this and we weren't gonna tell him this at this point because he was dying, right? So we're looking at him and like his pressure's tanking and he's just not doing good and we do not want but 2 massive transfusion protocols on him, right? So we're like dumping blood in him, we're dumping fluids in him, all kinds of stuff. Then we get the kid and basically anything from the waist down, actually from the chest down, I forgot about his ribs, is broken. And he's not a small boy. He's like super tall, big bulky kid. He's in this big beefy truck. And so he has all kinds of stuff broken. Remember the pictures? What is the one thing we forget with an orthopedic injury, right? There's a massive amount of blood loss. Well, boy didn't just have an orthopedic injury. He broke both femurs, both tib fibs, broke his ribs, not to mention we don't know what else is going on, right? So neither of these men should have stayed at our facility. I had experienced nurses, I had a manager saying, can we transfer these people? I had Lifeline on standby, we lost them to another run. I had Transcare medic, one of their best medics on standby, we lost them to another run. We admitted both of these guys and immediately transferred the older guy because actually went around the trauma surgeon to get it done. The young guy, the trajectory of his plan changed when we changed trauma surgeons. When I had one of my more experienced guys start seeing him, then we started going, no. Now, the family did cause a lot of that delay because they just weren't connecting the dots, right? So I will tell you, we got called to the carpet. We, Union, as an organization, as a trauma center, we got called to the carpet on both of these. So we have to answer to people, right? And those people are the level 1 trauma centers. And we get an email, hey, we need to have a meeting. They went actually separate, right? The older guy, I think, went to Methodist. Yes, the kid went to St. Vincent.
No, they both
went to St. Vincent, okay.
Yeah.
And they're like, as polite and professional and amazing as you can, they're like, you screwed up. And we did. We should have never kept these guys. But I will tell you, our perspective of yours, was great. I would love to see what you end up presenting, because from what we saw, it was phenomenal. They both lived, they're both gonna do okay. It's not gonna be great, right? When you're 20 years old and all of a sudden you can't walk, that's pretty devastating, right? I don't know at what point the older guy figured out that he'd lost his wife, because he was intubated when we finally got rid of him.
They told him before he went to rehab.
Okay,
Yeah, so
so,
he doesn't have any recollection of what the wreck, but he is aware that his wife died.
yeah, so, yeah. So it was bad. There's a lot of things we could have done better. I felt like the EMS piece was great. Always make those phone calls. I looked at Heather and I said, "Where have you been?" She goes, "I didn't even know what's going on," because they were in meetings. So.
Was there any consideration for team flights or was weather bad?
Weather. It was
Okay.
bad weather. Because then we had another multi-accident last week, 2 weeks ago, when we had the bus. I will say those are increasing. Please continue to increase those, because I'm listening to that going, we've got one, like the bus driver was ejected from the special needs bus. They flew her sort of from the scene. The scene was literally spitting distance to the helipad, so I think they drove her out there, but. So I am hearing scene flights more and more and more. Keep doing that. These guys are level 1, being a level 1 center. We are not a level 1. We don't pretend to be a level 1. We're a 3, but as we had said in a previous meeting, there's nothing you can't bring to us, okay? Our ER guys are phenomenal, and our ER guys were even going, "You want to transfer, right? You know, this fault lays back on trauma," because they were like, "Transfer, right? We want to transfer this, right?" Because these are not things that we usually keep. I was shocked when the orthopedic surgeon said, "No, I think I'll take him to surgery." I'm like, there is nothing not broken. So, but EMS did a fantastic job. Your times blew me away, how good your times were considering what had to be done on scene. The scene flights are increasing, keep increasing the scene flights. This one was rain, I think.
Yeah,
Like this was a
It was
nasty
like the
rain.
temperature was like
February.
32,
Yeah.
33, and it's misty, so
Yeah.
they would have felt nice.
Yeah, they both should have left the ER to a level 1 where they needed to be. I think the younger man would have fared better. His care here was great, which is what kind of misled the family a little bit, because he was getting good care, but he needed care that we can't provide. We don't do it. He needed to be on ECMO. We don't do some of those surgeries here. He needed those surgeries. And even those surgeries had some problems. I'm not gonna get into that. But one of the things that they were like, was like, this shouldn't have happened, this should have happened. But as far as the EMS perspective, I thought it went fantastic. And I even said afterwards, I said it was like a dance and everybody knew their dance. The only opportunity I would have even said was, stay with your patient and force us to do the 60 seconds. And I'm gonna tag Miranda and say, we have got to get that back in play, because it was utter chaos. But yet it wasn't chaos, if that makes sense.
It was.
It was organized chaos.
It was controlled
chaos. Yeah, it was controlled chaos. And even with the mental health folks, when we thought we thought they were all 4 gonna be serious, like Celinda's like, all right, this, and this, here's your 4 rooms. And then they came in and they weren't as critical, but then they ended up being critical. Any questions for me? There's nothing we can't take, but there's a lot of stuff we won't keep. If that makes sense.
Thanks, Tina, appreciate it. Jimmy, you ready?
Yep.
We're gonna do our educational presentation on CPAP, and I'm sure he's going to expand a lot into that. You have as much time as you need.
All right, so my name is Jimmy McCanna. I'm a director of respiratory therapy and some other areas of the hospital, and I'm gonna present today on CPAP. I talked about this a lot, but I'd really tried to focus this more towards the pre-hospital if I can. So, and then I'll get into a little bit of technical side. So I'll try not to lose you. I'll try to make sure that it all makes sense, and this is the reason why we're teaching it. Expanding your respiratory arsenal. Actually, I use Google Gemini for that, so I'm not really creative. Okay, so what is CPAP? We know that CPAP is an acronym for continuous positive airway pressure. The best thing to know about CPAP is you get pressure during the inspiratory cycle and the expiratory cycle. So some people will call it PEEP, but it's really not, because it's continuous. And so during both of those cycles, you'll have that. Down here at the bottom, it says it improves oxygenation and ventilation. So I'll put a little asterisk by ventilation, because whenever you think of somebody ventilating, you want to think of them getting rid of CO2. And they actually do get rid of a small amount of CO2 with CPAP. And I'll just a small explanation of that. That's because there's a continuous airflow that's going through the airways, and that does help to recirculate CO2. So you can't ventilate somebody who has a really high CO2, but you are getting rid of some CO2 with CPAP, but we mainly think about it used for oxygenation. Some key points, frequently encountered in pre-hospital setting, and also these are just pictures that I've taken that are kind of EMS pictures. Life-saving intervention for respiratory distress and expand your ability to manage critical respiratory patients, because we know that just delivering oxygen really takes an effort upon the patient side, and we can deliver high percentages of oxygen, but by increasing the pressure inside of their airways, we're gonna optimize, and I want you to, I'll go back to this, we're gonna optimize every aspect of their oxygenation potential. So we're gonna optimize every alveolus that they have. So a couple different things, how it helps, and I'll talk more about this. Increases FRC, or functional residual capacity, and it sounds like a big word, but I'm gonna try to have it make sense for you. And then preventing alveolar collapse, reduces work of breathing by decreasing inspiratory effort, because that we're delivering that flow and that pressure during their inspiratory cycle. We're actually gonna augment their breath they're taking in. If you know it or not, you actually have to pull, when you take a breath in, you have to get it down to your terminal bronchioles for oxygenation, and you're pulling through resistance every single breath. Well, a patient that is short of breath is gonna have a much more difficult time because of that space. You'll notice this with a patient that we would put a new trach on, and because when they have a tracheostomy, they bypassed all of this upper airway resistance, and it's much easier to get their breath in. That's what we're doing for a trach patient. CPAP helps to force that in and also decreases their inspiratory effort. It also improves oxygenation by increasing the pressure inside of their airways and almost like forcing oxygen across into their bloodstream, which is most important. And then decrease venous return. So this is something a little bit new that I've not taught on before, but it actually decreases venous return. And we know that, and we always kind of think of that as a bad thing in the ICU. But for our patients that are in these acute pulmonary edema type situations, it actually could be a good thing. And so I'll explain that in a second. So that's a little bit of new stuff when it comes to CPAP. So back to functional residual capacity. Please don't let this get to you at all. But this is one of the waveform graphics that we look at as respiratory therapists when we're doing spirometry. If anybody's ever had a pulmonary function test or spirometry, this is an indication of, and I'll show this right here. You see the actual waveform there, looks like a sine waveform. That's the tidal volume. So that's the normal amount that you breathe. Well, this entire box over here is your total lung capacity. So we have this total lung capacity. We use a small amount of it, as you see, for a tidal volume. And then what we have is a couple other areas, and I won't get too deep into it, but we have like its expiratory reserve, or sorry, let's talk about inspiratory first. Inspiratory reserve, so that's the deepest breath that you can take in to the very top. You're actually reaching your total lung capacity. It's usually restricted by your chest cavity or anything in those ways. So if you get to your inspiratory reserve, you see you hit your top of your total lung capacity, but when you exhale, you can never really get down to your residual volume. There's always a small amount of air that actually stays in your lungs at all time. Doesn't matter how far you exhale, you'll never get rid of it. The only time you ever might lose your residual volume is if somebody gets the quote unquote air knocked out of them. Like if in a football injury or something like that, you can lose a little reserve volume. And I always like the term, it's like when that time when they go, you know, when their body's trying to recover that residual volume. That's really important. In COPD patients, that residual volume actually increases, decreasing the amount of functional lung space. But what we're looking at with CPAP is increasing this area right here. So this expiratory reserve volume, this functional residual capacity is ERV plus RV. What we want to do is optimize or increase that expiratory reserve, because that's going to help our patients quite a bit. I will not quiz you on that. All right, so how does it also decrease work of breathing? I talked about this just a little bit earlier, and this is slightly more technical, but it should make a ton of sense. We have what's called physiologic dead space inside of our airways, and there's two aspects that go into it. We have anatomical dead space and we have functional dead space. Anatomical dead space we cannot do much about. That's actually the space from your lips all the way down to your terminal bronchioles. That's just dead air. And the only way, there's really no way to overcome that unless you trach somebody, then you bypass that upper airway. But anatomical dead space is about 100 milliliters of air for most people, for most adults. Not much we can do about that. That's all conducting airway, no gas exchange going on. We just got to kind of deal with it. You'll see in the hospital, we overcome this by heated high flow cannulas. So when we put them on heated high flow cannulas, we force that air down, we wash out anatomical dead space and get oxygen more available. Because when you take your breath, for the first 100 milliliters of air you take in, it's mixed air. It's higher CO2s, it's lower oxygens, and a lot of nitrogen. So you're not actually getting room air oxygen to your lungs until 100 mLs into your breath. That's just kind of a way to think about it. Now, what we like to do is try to offset functional dead space. Two different things that cause functional dead space. And that means that we have a functional alveoli in most cases, but we are not getting oxygen or gas exchange. Atelectasis is one, collapsed alveoli. So due to any kind of lung disease, we have pneumonia, COPD, you can have atelectasis in those areas. CPAP can also treat that. And then also another aspect, a little harder to treat, is decreased blood flow to those alveoli. So you can have an awesome alveolus, but if you have a clot somewhere and you can't get blood flow to it, you can't have gas exchange. So we're really looking at trying to fix their functional dead space by using CPAP. So a couple other things, and it just for to have a couple nice pictures on here. Cardiogenic pulmonary edema is one of the really good indications for pre-hospital CPAP, because what it's going to do is actually going to, and the reason that fluid is actually coming across into the alveolus is usually because the left side of the heart is failing. The pressure inside the vasculature, the pulmonary system is increasing, and once it increases enough, it actually forces fluid across kind of the wrong way. It's going back into the alveoli. One thing that we try to do, I mean, we know that the diuretics and inotropic medications can help with that, but one way to really optimize your diuretics is by giving CPAP, offsetting the pressure, and actually causing pressure to come down and force against that fluid that's coming into the airways. Force it back into the bloodstream so that we can get it out with a diuretic. And so it's kind of a synergistic effect because when they work together, it works quite well. Another problem with atelectasis, and CPAP does treat that also, is something we don't talk about a lot, but it's surfactant, decrease in surfactant. Surfactant is so important inside of our airways. And when you work with preterm neonates, you know that because that's one of the last things to mature in a preterm neonate. But what surfactant is something that keeps your airways open. Without surfactant inside your airways, alveoli are just going to be like a flat balloon, and they're going to collapse, and they're going to be hard to reopen. So by having atelectasis, we're already decreasing the amount of surfactant inside of our airways. There's not been any kind of trials or anything to give exogenous surfactant to adults, but we do it in the neonatal world all the time. And it's, if you've ever seen it before, it actually is really amazing. We use minced pig lungs and we insert it into the endotracheal tube in large amounts. We're talking about preterm neonates and we're giving milliliters of it and it looks like you're drowning them and then immediately they start oxygenating. So, but with atelectasis, you're gonna have decrease in that, so you're gonna need some extra pressure to hold those open. Near drowning is also one of those situations that can cause atelectasis because they might have some washout. And anytime you get something that washes out through your alveoli, that can decrease your surfactant level. So those are two different areas for oxygenation. So decreased venous return, this is kind of a little bit of a revelation to me. So just by doing a little bit of research on it, I always think of decreased venous return as a bad thing. Like we put way too much PEEP on our ventilator and it's gonna cause squeezing of the heart and it's gonna cause their blood pressure to drop. And they're like, hey, turn down their PEEP. We're gonna put them on some pressors or whatnot. But actually in the case of cardiogenic pulmonary edema, it actually can be a good thing to take a little bit of pressure off the heart. So this is normal breathing. Under normal circumstances, you know, and we talked about that pneumothorax earlier, we breathe with a negative pressure drive. So there's continuously this negative pressure in your interpleural space that causes you to breathe, decrease the diaphragm contracts, and you get more negative space and you bring in air. It's an amazing system the way it works. But by adding CPAP in, actually what we do is we turn this all into a positive pressure space. And so when you do that in short term especially, you're gonna increase the pressure inside your vena cava, which is gonna decrease your venous return. Now, why is that good? Because the heart is already overloaded in a lot of these cases and they're hypertensive. Now, if they were hypotensive, that's something I'll be worried about. But if they're hypertensive, I'm not gonna be super worried about decreasing the amount of return to the heart. So kind of a new revelation for me, and it makes a lot more sense with use of CPAP when somebody is in pulmonary edema, cardiogenic pulmonary edema. So just the indications, just so I probably should have put this in the second slide, but that's okay. Indications for CPAP: acute pulmonary edema, cardiogenic specifically, COPD exacerbation, asthma exacerbation, severe, moderate to severe asthma exacerbations, pneumonia. This is usually going to be a pneumonia that's going to be somebody who can't manage their oxygen level en route with normal non-rebreather or any kind of high FiO2 devices. Respiratory distress from near drowning. That's where I was talking a little bit about the surfactant loss. And then obstructive sleep apnea, which, you know, the majority of the world has, that's just untreated. And so you know that a lot of patients have obstructive sleep apnea. It's always a nice thing if you're on scene or in the home to know that you see a CPAP at their bed or whatever it is, just to know in the back of your head, because downstream we can fix a lot of problems, but if they don't tell us they have obstructive sleep apnea, they come into the hospital and then they start closing off when they go to sleep in the hospital. They don't rest, they wake up, feel terrible, and their body can't heal really during that time. So it's nice to know, oh, by the way, that patient had a CPAP at home. We can usually go back and put them on some generic settings, but that they have obstructive sleep apnea, especially if it's treated, it's probably bad enough that it needs to be treated all the time. Contraindications is kind of one area that, yeah, I'm sorry, there we go. So absolute contraindications, there's definitely some of those. Apnea, definitely not for CPAP. This augments their oxygenation space. This does not augment their respiratory rate. Treatment for apnea, respiratory, obviously is intubation and fully taking control of their breathing. Inability to protect their airway. So if there's anything that you suspect that they can't protect their airway, then you do not want to put a CPAP on that patient, because you will actually, and it goes down to acute active vomiting also. They vomit that up and they can't protect their airway. That's just going to force it straight down into the lungs with extra pressure behind it. Pneumothorax, facial burns. Facial burns is mainly because you cannot, well, for one, you just shouldn't mess with them. But the second thing is you can't maintain a mask seal. It's really, really important if you're using this in the pre-hospital setting that you can maintain a mask seal. If you cannot, you probably should not be using the device because it can be counterproductive. And then relative contraindications, hypotension, because if they're hypotensive and we increase that pressure inside their chest, decrease venous return, we can make them more hypotensive. Claustrophobia, okay, whatever. And then altered mental status, definitely not. Recent gastric surgery, and then nausea. That's like the pre-vomiting-ish. And so I just put a pneumo over there on the side just for pictures. This is actually one of the devices. My brother works for Terra City. Asked him what kind of device they have. I don't know if this is common in other areas. This is the device that's used for Terra City for CPAP. It's called O2 Max. The number one thing that we tell all of our respiratory therapists is familiarize yourself with your equipment, and you guys know that well, but know how these masks go on, know how you're going to teach the patient when you put them on, because that is such an important factor in making this all work, is making sure you know how this is going to work. Even how this feels in respiratory therapy school. We actually wore BiPAP, CPAP. We let our classmates turn up pressures, change pressures, so you can have a little bit of an understanding of what your patient is feeling, and then you can help to talk them through that. So interesting thing is that these come with a fixed FiO2. So the FiO2 for these, and I don't believe Terra City has one that you can change. Some of them you can change from like 30 to 60 to 90%. This is 30% FiO2. And so that's the equivalent of 2.5 liters in your nose. That's a pretty low amount of oxygen flow. So if they're hypoxic in any way, you're going to have to add supplemental oxygen. We do not recommend putting a nasal cannula under it just because it really presses down on the skin. But since your transport times are short, whatever feels good in your case. But this just gives 30% oxygen, which if they're in an acute exacerbation or COPD or congestive heart failure, then 30% may not be enough. There's also different PEEP settings. I always recommend starting at 5, and that's P per CPAP level. And so that's kind of the standard for the bottom end. Some patients will want more. And when I say patients that'll want more, your COPD patients may want more because they really like flow, and that's how we treat a lot of them, is increasing their flow. And sometimes with adding a little bit more CPAP, it feels more comfortable to them. That's really the key, is the mask fit, making sure it's comfortable to them so they can wear it during the transport. And then also it has a disc adapter that goes into the tank and an air filter on it. Always start flow at 5 and then slowly increase, monitoring closely from the initiation. So one of the things that I think that would work the best is that if you have this on a patient and you're monitoring the patient, obviously got lots of data on here that we would like to monitor, including pulse ox, respiratory rate, exhale CO2. So there's a little bit of, there's not a great device to measure exhale CO2 under a mask, although quite often cannulas are used. And really think about your exhale CO2. You're not going to get a perfect number, but you're going to get a baseline. And you're going to want to look at that baseline and look at fluctuations 5 above or 5 below of that. And then you're going to know that there's actually some changes going on down inside of their vasculature. But you're going to look at a baseline for them, and then you're going to monitor that throughout the time. One of the keys to doing this, because there might be a little bit of anxiety about putting CPAP on, is during this time, closely monitor your patient and look for reasons or trends to discontinue. And that sounds kind of terrible because I'm going to put this on, I'm going to look for reasons to take it off. But if you're looking for reasons to take it off, your patient's going to be comfortable the entire time. Because since transport times are somewhat slow, it can't help to make sure you're monitoring that and saying, okay, 3 to 5 minutes on blood pressure to see if that's changed at all. I'm going to watch their sat, I'm going to watch the heart rate. If anything starts to go awry, get them here quick and remove the CPAP because something's not quite right with it. It could be a seal. It could be maybe they have some boli emphysema that we didn't know about. But that would be what I would do. If you should see improvement from the time you put the CPAP on, you should see improvement. You shouldn't see any decline at all. That's really important. That's all I have. I always do a shout out. I have a YouTube page, 27,000 subs. If you're ever interested in subscribing to it, a lot of respiratory different things on it. So hopefully you're all subscribers already.
Oh, yeah. Absolutely.
Thank you, Jimmy. Appreciate that. Really
Thank
good.
you.
Anybody have any questions for Jimmy before I get it done? Thanks, Jim. Appreciate that. All right, guys. Couple things I wanted to bring up. First and foremost, be sure hook into the QR code. If you didn't sign in, hook in there anyway. You should be able to, it'll ask your name, your service, your PSID number, that kind of stuff. Get that on there. Sign in sheet if you're up here. Hey, we're having the EMS challenge. I know we've had, we don't have a whole lot of teams signed up right now. I'd like to get as more teams we can. We're probably going to change that from being a 2-day thing to a 1-day thing. So it'll just be Tuesday the 20th. It will be down at the mall. We're only because we won't have to be out and get burnt to crisp like we did last year outside because the one day it didn't rain. That wasn't the day we did that. EMS week, our luncheon is going to be on Wednesday the 21st from 11 to 1. It'll be in the South POB lot like normal. The mayor will be here at 11:30 to do the EMS proclamation. So please come and join us for lunch. Rick's Barbecue again. They'll be here doing that stuff. Transcare is taking care of the desserts. Fire department's taking care of the drinks. There'll be gift cards, of course. There'll be EMS gifts and a couple other things that we're going to be able to give away. Skills days, the last week of July, 29, 30, 31, August 4th, August 1st, 9 to noon. For skills days, for you guys to get your skills in if you need them. Be sure and show up and you can get all of them done in a half hour. So, anything else? Anything else I'm missing? I think that's everything we talked about. So, hey, one other thing too, do me 2 favors. One, keep an eye out for water. I know that's out there. It's nasty. You guys out in the county, be smart. And the other thing to keep in mind, if you're going to have an extended scene time, please just document why. Let us know. I can go in typically and read things and give reasons and tell them why, but mainly if you're going to have extended scene time past 20 minutes, especially on a trauma, just let us know. Write it down for us. Just tell us why. Give us an idea. Hey, it's hard to get the patient out of the house for this reason. Great. That's all we need. We just need to be able to justify for the trauma registry. Okay. I really appreciate that. If you guys don't have anything else, if you haven't signed in, be sure and sign in. If not, thanks a lot. Appreciate it.